Hello, Namaskar. I am Dr. Assuma Beevi, President, Nurse Researcher Society for Innovations, abbreviated and called as NRSI, and I am working as Dean, Aster MIMS Academy, Calicut, Kerala. I will be talking to you on fundamentals of ICU care. We all know that intensive care nursing is a highly specialized field that combines advanced clinical expertise, technological competence, and compassionate patient-centered care. ICU nurses are essential members of the healthcare team, ensuring continuous monitoring, timely interventions, and patient safety and support for the families during critical illnesses. And the next slide talks to you about ICU concept and core purposes. Actually, when we think about ICU, this is an organized system for care of critically ill patients. And ICU care provides intensive and specialized medical care, specialized nursing care, enhanced monitoring capacity. And the primary goal of ICU care includes prevent progressive physiological deterioration while the underlying disease is actively managed. A patient who is coming to critical care area or ICU, we know that they have a lot of medical issues. We wanted to prevent further physiological deterioration and the underlying disease is managed carefully. This is the primary and the most important goal of ICU care. The role of nurses in ICU care, the first, not only nurses, ICU care role is patient survival. We have to make the patient survive and come back to the life. So here, vital for improving survival of critically ill patients. This is achieved through continuous monitoring and maintenance of vital functions. The next, there is a framework which we call Fundamentals of Care Framework in ICU. And what is it? High quality fundamental care is highly valued by ICU patients and families. So the core dimensions here is nurse-patient relationship, integration of physical and psychological care needs, and supportive care context. The clinical significance of this framework. Nurse-patient relationship is the core of fundamentals of care framework in ICU. It supports person-centered holistic care, focuses on individual physical needs, recognizes the impact of care environment on care delivery, including the emotional and spiritual needs of the patient. Then in ICU, we usually go for multidisciplinary and collaborative care. This is very important in critical care units, and we have to see what are the essential components of critical care nursing. Here, it's a collaborative care. As I told you, it is a teamwork. Nurses collaborate with many other healthcare professionals like physicians, respiratory therapists, physiotherapists, pharmacists, and other healthcare professionals. And we maintained a team approach or team-based approach in ICU or critical care unit. Here, interdisciplinary rounds enable comprehensive assessment and integrated care, leverages specialized expertise of team members, facilitate timely intervention and treatment adjustment. When we talk about interdisciplinary rounds, the physician will be there as the leader of the team. Nurses will be talking about the nursing aspects. The respiratory therapist will talk about the pulmonary outcome of the patient. Like that, so many people will be included, and the pharmacist even included in many of the hospitals where they talk about the drugs, effects, side effects, how it will act on the patient, what physiological needs will be changed or will be maintained, and how the pathological condition will be treated. All these will be coming there, and there is a great impact. This interdisciplinary team-based care has got high impact or greater impact on the quality of care provided. So when there is a multidisciplinary collaborative care in critical care, it improves overall care quality, promotes a cohesive, goal-oriented team, drives optimal patient outcomes. Then role of critical care nurses. Being nurses, what are the roles of these nurses in a team in the ICU? They manage critically ill patients with complex, unstable conditions. And here, not like other routine wards, they perform advanced assessment, continuous monitoring, and rapid interventions. They interpret complex clinical data and administer therapies. They coordinate care with multidisciplinary teams and deliver holistic patient and family support. So here the nurse has got multiple roles, and the nurse is the key person here in the multidisciplinary team, because the nurse will be there for 24 hours, round the clock, watching by shift, watching the patient, assessing the patient, reporting about the clinical condition of the patient to others, and seek their help also if needed, like that. And there are a lot of machines and monitors which she needs to be coherent and cognizant about each machine and how it will be used in the care of this critically ill patient. So role of critical care nurses are very important. Then core responsibilities and essential skills of ICU nurses. See, as I mentioned earlier, the continuous monitoring of vitals, neurological status, and treatment responses. This will help for early recognition of clinical deterioration or improvement, then rapid clinical decision making and timely interventions. When a patient is thinking, if the nurse cannot understand what is happening to the patient, how can she take a timely decision? So rapid clinical decision making and timely interventions are very important, and nurses should have proficiency in advanced therapies like mechanical ventilation, hemodynamic monitoring, renal replacement therapy. This means they have to be very careful about identifying what is happening with the patient. So then competence in operating and troubleshooting critical care equipment. There are a lot of monitors, machines, medical equipment in an ICU. The nurse should know how to manage this, and also small issues coming with the machines. Nurses should be alert and they should know how to handle it and manage it. And I remember one of my teachers, he was a teacher of medical surgical, used to say that nurses should have 18 skills and a small skill of doing electrical connections, changing bulbs, and connecting monitors. All these things he used to tell us. The same way, every nurse working in the critical care unit should be able to manage the troubleshooting. They are not engineers or biomedical engineers, but they should know how to handle small things, and this will ensure safe and effective care in high risk, high acuity settings. Then clinical role in patient management for ICU nurses. They should receive detailed handover from the previous staff nurse or shift nurse. When you are changing the shift, get a detailed handover. They should perform head-to-toe assessment of the patient, then check and secure IV lines, central venous and arterial lines, Foley's catheters, drains. Then they should look for the monitors functioning, verify monitors ventilator settings and alarms, check and label intravenous fluids and medications, plan shift-specific nursing care, and participate in rounds and implement patient care. That means the nurse has to follow nursing process, plan the care for each shift separately based on the head-to-toe patient assessment. That is very important, and for each shift they may have new nursing diagnosis coming and new nursing intervention need to be planned and carried out. So they have, for each shift the patient should be assessed. Then bedside nursing care activities of an ICU nurse. They should deliver essential bedside care and maintain patient hygiene, monitor vitals, neurological status, fluid balance and ventilator parameters. Administer medication safely and ensure nutritional support. Monitor blood glucose and fluid electrolyte balance. Prevent pressure injuries and support early mobilization. Assess pain, sedation and promote sleep hygiene. This shows that a list of activities a nurse has to do in an ICU for each shift. That means it is a personalized care for each patient, and each patient assessment stand out, and nurses have to plan the clinical interventions and perform or do the needful nursing interventions in time. That is why Indian Nursing Council have made the patient-nurse ratio as 1:1 in critical care units. The nurse strategies for delivering fundamental care. Simply they cannot provide fundamental care. They should have some strategies. So let us see what are these strategies. Build therapeutic relationship through effective communication. So I have already mentioned that it is a team-based approach. So we have to see that we do this in the same way. So effective communication between and within the healthcare team is very important. Then provide orientation, reassurance and reduce patient anxiety. You may be thinking in ICU most of the patients may be having altered sensorium, and how can we orient them? But there are a lot of techniques through which we will orient the patient. And we all know that hearing is the last sense that goes out from a person. So we can talk to patient even if they are not responding, they hear about it. So nice words has to be talked to them and talk to them nicely. This is very important because as I told you, the last sense that goes out from a human being is hearing. So remember that. Collaborate with the patients to set care goals. Then advocate for individual patient needs. Deliver personalized, comfort-focused care. Educate and involve families in care. ICU also we talk about family-centered care. The patients who are critical will be admitted in ICU and the patient is separated from the family members. They may not get enough details about the patients. So we have to see that a nurse being the key person, we have to see that the patient's family members are involved. They may not be able to provide the care to the patient, but you should inform them. You should show the patient to them. Like you can have a video for the patient's relatives who are waiting in the waiting room, so that they will know that their relatives are or their important people at home are kept safely, taken care, like that. So this is a very important need of the patient and families. So strategic is for delivering fundamental care is very important. Challenges faced by nurses in delivering fundamental care. See, I have mentioned to you about the communication. First thing is communication. Communication barriers with unresponsive or voiceless patients. See, we know that most of our patients are ventilated, mechanically ventilated. They will not be able to talk to you. They may use actions. You may have to use various other strategies to communicate to the patient. So what we have to do, the common barriers we have to identify. These common barriers are either patient-related barriers, environment-related barriers, healthcare professional barriers. These three types of barriers are very common, and then organizational barriers. This four important categories of communication barriers exist in critical care unit where most of our patients are voiceless. Then complex clinical conditions and competing care priorities. A patient may be coming with multi-system failure like kidneys. There may be a myocardial infarction. He may be having the same patient may have some problem with the kidneys. So you may have to take care of the heart. You may have to give a drug that may help in relieving the cardiogenic shock and all, or myocardial infarction. At the same time, the patient may have to undergo a hemodialysis. Multi-organ system failure may be an issue that you may see in ICU. So you have to think about if a patient comes with an acute stroke, what we will do. He may have other conditions also. So complex clinical conditions and competing care priorities. So which care has to be given first? If a patient is coming with a stroke, you may have to give a thrombolysis medications first. A patient coming with a myocardial infarction, again, you may have to give a medicine that combats a myocardial infarction. Then you may face, with these competing strategies or competing situation, you may face staff shortages, time constraints and limited resources. And limited ICU experience and emotionally demanding interactions for the wise nurses, means newly recruited nurses or nurses who are newly posted in intensive care units. Then general ICU admission criteria. So who all will be kept in ICU? They said it is multidisciplinary. Now people call it as MDICU, multidisciplinary intensive care units. So we may have different types of patients getting admitted to intensive care units. These are acute illness or injury requiring close monitoring or specialized treatments. Then intensive management needed for multiple organ failure. Then high risk of organ failure with a probable death without ICU care. And complex medical conditions needing multidisciplinary management and complex surgical procedures needing intensive monitoring. All these people are considered to be admitted as a general criteria. Then what are the specific criteria for a ICU admission? These are again system wise it is written here. You can see the first one is respiratory. Acute failure and need for ventilatory support. Massive hemoptysis, impending intubation. Then second, cardiovascular issues like cardiogenic shock complicated with myocardial infarction, unstable arrhythmias and post-cardiac arrest. Then next one, neurological conditions like a coma, acute stroke with AMS. AMS is altered mental status, intracranial bleed, status epilepticus, severe head injury. Then you can see the renal or metabolic causes like acute renal failure requiring RRT, then severe electrolyte disturbances with instability. Then gastrointestinal conditions like life-threatening GI bleeding, like cirrhosis liver, then hepatic failure, severe pancreatitis, then drug overdosage with AMS with airway compromise, seizures and instability. Then surgical conditions like post-operative patients requiring intensive monitoring or ventilatory support. Then ICU admission process. Simply you cannot keep a patient in ICU. We have to confirm that the ICU admission criteria are met by the patients to be kept in ICU. So let us see how we can admit a patient into ICU. Confirm ICU criteria through comprehensive clinical assessment. We have seen the general criteria and specific criteria. Now we have to look into that whether this patient should be admitted in ICU, because ICU beds are less. We cannot admit everybody who needs critical. We have to prioritize and admit the patient. Then assess illness severity and patient benefit. Use scoring systems like simplified acute physiology score, then sequential organ failure assessment, then acute physiology and chronic health evaluation. Then we have sepsis related organ failure. So far can be used for do sequential organ failure assessment and sepsis related organ failure assessment. Then identify appropriate candidates and admit accordingly. Ensure ongoing monitoring and treatment adjustment. So these criteria must be followed, and ICU admission process is this. First, confirm the criteria through a comprehensive clinical assessment. Then look at the illness severity and what potential benefit if a patient is kept in ICU that patient will get or get. Then for this you can use scoring system like SAPS, SOFA, Apache, etc. I have told you what is SAPS. SAPS is simplified acute physiology score. Then SOFA is sequential organ failure assessment or sepsis related organ failure assessment. Then Apache is acute physiology and chronic health evaluation. Then we have found out what are the criteria to be admitted to an ICU. Now we have to see what is the research or discharge policy. Once a patient is admitted to ICU, how we will discharge this patient. There are policies. For each hospital, it may vary little bit, but majority of the things are same. So standardized protocols ensuring safe, timely and cost-effective ICU discharge. The components of ICU discharge plan is assess patient condition and functional status, develop and communicate discharge plan with patient and family. This is very important now. Sometimes our people forget about telling about the discharge. If it is a private hospital, they have to find out the money and to pay the bills and all those things. So we have to tell them the approximate time of discharge and all those things. Then arrange required services and follow-up care. Required services like if a patient needs an ambulance to go home, a transport facility to go home, then again whether they need to come for follow-up into the same hospital or nearby hospitals, like that follow-up care. Then educate patient and family and evaluate the response. You teach them and find out whether they understood or not. That is the evaluate the response. That is why we say that we have to evaluate the response of the patient. Then general criteria for ICU discharge. The patient should be physiologically stable with no ICU level care for the last 12 hours. That is why after the immediate care, usually we transfer the patient to the step in ICU because We wanted to find out whether they are stabilized before getting discharged. Then transfer for specialized care or on patient or family request. Transfer to other hospital when specialized care is required. Then now the other way around, we have to see how we are going to assess a critically ill patient. The general consideration use a systematic approach and checklist to improve outcomes. Incorporate fast hugs bid in assessment. I'll tell you what it is. Then apply evidence-based care bundles. Ensure effective communication and document. Then what is this fast hug bid? Each letter stands for a word. That fast hug bid is F is for feeding. Ensure adequate nutritional support. Then A for analgesia, assess and manage pain effectively. Then S is for sedation, monitor and optimize sedation levels. T is thromboembolic prophylaxis. This may be needed especially if ICU stay is longer to prevent deep vein thrombosis and pulmonary pneumonia. We know that pulmonary pneumonia is a pulmonary embolism is a major threat for ICU patients. Then H is for head of bed elevation. Then U for ulcer prophylaxis. G for spontaneous breathing trial. Then B for bowel care. I for indwelling catheter assessment, and D for de-escalation of antibiotics. So I hope you understood what is fast hugs bid in assessment, and this is very important. It has got very high significance in ICU care, that because it provides a structured daily checklist for ICU nurses, improve patient safety and quality of care, and reduces complications such as infections, DVT, stress ulcers, and ventilator-associated pneumonia. Then promotes multidisciplinary communication and evidence-based practice. So fast hug bid in assessment is very important. Then next is ABCDE approach. This is for the initial assessment: airway, breathing, circulation, disability, and exposure. These are commonly known to most of us, and even the students who are learning in critical care will learn them about ABCDE approach. Then ongoing assessment is head-to-toe examination for scheduled and subsequent evaluations. So assessment of a critically ill patient, first is the general consideration. In general consideration, you use systematic approach and checklist. Fast hug bid in assessment is very important, and it should be incorporated. Then apply evidence-based bundles and ensure effective communication and document. The next is, way of assessment is ABCDE approach, where you know airway, breathing, circulation, disability, and exposure are mentioned, assessed as initial assessment, and ongoing assessment is head-to-toe examination. Okay, next let us see the principles of patient assessment in intensive care unit. As earlier mentioned, there is an initial assessment, and then comes the subsequent assessment. Initially, we take a focused history because we wanted to intervene the patient. We wanted to give the treatment and save the patient. So, focused history will be taken first, and subsequently we will be doing a detailed history. Then physical examination, ABCDE approach, and later after admitting we will do the head-to-toe assessment. Then investigations, we do first focused investigation and then detailed investigation. Diagnosis, physiological diagnosis and diagnosis of life-threatening issues will be done in the initial testing, and finally we get the definitive diagnosis, but after all diagnostic test and evaluation. And treatment is first we will do the resuscitation, we may do the CPR and stabilization of the patient. Finally, we will look at the underlying cause of the illness, we will go for the definitive treatment. Then reassessment will be done response to resuscitation, and finally subsequent assessment will be at recovery. Next we will be looking at the vital signs monitoring. The core vital signs, we use NICE guidelines. NICE guidelines means National Institute for Healthcare Excellence. In that we recognize, first thing is recognition and response to acute illness. The second thing is about the airway and respiratory management. Third thing is hemodynamic monitoring and circulatory support. The fourth one is nutrition support. Fifth is sedation, analgesia and delirium management. Sixth is infection prevention and control. 7, prevention of ICU complication. 8 is communication and family-centered care. 9 is rehabilitation and recovery. And the core vital signs we include is heart rate, respiratory rate, blood pressure, oxygen saturation, level of consciousness and temperature. And in blood pressure, that reflects the pressure during systole and diastole. And key parameters are systolic blood pressure, diastolic blood pressure and mean arterial pressure. And the respiratory rate, when we look at, the normal is 12 to 20 breaths per minute. Most sensitive indicator of clinical deterioration is abnormal going above this 20 and going below 10 per minute is considered as abnormal tachypnea and bradypnea. See, if it is going above 20, we consider as tachypnea, and if it is below 10, it is bradypnea. Then pulse, that reflects the cardiac output and circulating volume, assess rate, rhythm and strength. And ECG is essential for rhythm evaluation, because if it is there is arrhythmias, arterial flutter, etc., we have to have an ECG, then only we will be able to find out. Then again, continuing, oxygen saturation, we will be looking for non-invasive measure of arterial oxygen ionization using pulse oximeters. That is normally is 95 to 100, below 90 indicate hypoxemia. And temperature reflects thermoregulation and heat balance. That is, if it is hyperthermia, altered infection, sepsis, and even environmental factors like during hot season, like that. And then level of consciousness, key indicator of cerebral function assessed by Glasgow Coma Scale or AVPU. And if GCS is below 12 concerning and below 9 it needs airway support. Then neurological monitoring, essential for brain injury, post-neurosurgical patients and altered mental status. The Glasgow Coma Scale, everybody knows about it, assess level of consciousness and detects neurological changes. Intracranial pressure monitoring using catheter-based monitoring for severe head injury, and it will help to prevent secondary brain injury. Then hemodynamic monitoring evaluates cardiovascular perfusion to organs and tissues. We may be putting a central venous pressure, which we call as CVP, measure the pressure in the thoracic vena cava and reflects right ventricular preload and assess fluid status. Then pulmonary artery catheter, that is PAC, it will measure the cardiac output, pulmonary artery pressure, mixed venous oxygen saturation and guides fluid, vasoactive and vasoactive therapy. See, when we talk about preload and all,
all these things which I need not explain again. Then laboratory monitoring, frequent testing to assess metabolic status, organ function, and medication effect. In the first one, we do artery ABGs, that is arterial blood gases. This will help us to find out whether the patient is having adequate oxygen and the oxygen saturation is good or not. It talks about the ventilation effects and acid-base balances. Then electrolyte and renal function, we will be looking at the serum potassium, sodium, calcium, magnesium. We may be looking for creatinine and blood urea nitrogen. Then complete blood count will be done to find out whether there is any infection, anemia, and also the clotting disorders. Then fast hugs tub. Fast hugs with actually daily ICU care checklist, which I have already told you. Once more, I'll be discussing this. That is feeding, ensure adequate nutrition. A for analgesia and sedation, optimize pain control and avoid over sedation. Then S is for sedation, and then T for thromboprophylaxis, pharmacological or mechanical as indicated. Then head of bed elevate 230 to 45 degrees. U is ulcer prophylaxis, that is prevent stress ulcers. Then G is for glycemic control, maintain glucose below 180 milligram per deciliter. Then spontaneous breathing trial, perform routinely to find out whether the breathing, whether there is a chance for weaning from the ventilator. Then bowel care and catheters, monitor bowel function, review catheter need, and de-escalation, review and optimize antibiotic therapy. Then fluid management in critically ill patient. This is taken separately. It's a very important area because patient is on, sometimes the patient is unconscious or patient is in a ventilator. So hydration maintenance is very important. Overhydration may lead to weight gain and edema, and dehydration may affect skin integrity and also the cardiovascular status. So hydration and total body water need to be monitored. So we maintain the intake output chart and all those things. The history, thirst chart, weight, edema, losses, vascular volume, and assess cardiovascular status. These are important for assessing the fluid status of a person. Once you measure fluid status, you will find out whether the patient needs maintenance of fluid or a resuscitation of fluid. Then maintenance of fluid is balanced salt solution, usually a ringer lactate or like that and all. Target intake is 50 kg up to 1500 milligram ml per day can be given for that. 50 to 80 kilogram we can give 2000 ml per day, and above 80 kg 2500 ml per kg. This is the maintenance fluid rate. That means patients up to 50 kilogram 1500 ml per day, 50 to 80 kg 2000 ml per kg, more than 80 kg 2500 ml per kg per day. Sorry. Reassess fluid balance, hydration and thirst symptoms. If the patient is having issue with the fluid, then again a standard is balanced salt solution will be given. Bolus is, if dehydration exists, bolus dose will be given as 250 to 500 ml per for hypovolemia. Use blood products for anemia and major bleeding. This is the fluid management in critically ill patients. Then oxygen therapy and delivery devices. Oxygen is a must in the ICU, everybody knows. Whenever we, even laymen, when we say that the patient is admitted to ICU, they know that the patient is receiving oxygen. So assess the need for oxygen therapy. Acute hypoxemia due to pneumonia, shock, asthma, heart failure and pulmonary embolism. Then ischemia with myocardial infarction with hypoxemia. High oxygen may harm ischemic heart disease or stroke. That everybody must be diligent about it. Then oxygen, how can we deliver oxygen to the patients? Either through nasal cannula, low flow. That is 1 to 6 liter per minute. FiO is 24 to FiO2 is 24 to 40%. Ideal for high PCO2, no rebreathing. Then face mask, regular 5 to 10 ml per minute, 50% FiO2, minimum 5 liter per minute needed to flush carbon dioxide. Then Venturi mask, you can see these pictures there, refer to precise oxygen titration. Nasal catheter or nasal cannula provides the highest saturation. Research has found out that. Then pain assessment and management, we use different types of pain management scales. Usually faces is used for people who cannot talk or write by themselves. So use self-report, NARS or WARS, visual analog scale for pain assessment. Then pain management protocols are either non-pharmacological or pharmacological. Non-pharmacological means are providing music, cold packs, massage, relaxation techniques. Pharmacologicals are opioids, especially morphine and fentanyl. Then non-opioids are paracetamol and ketamine. You can see the pain scales given here. The nursing care of patients on NIV ventilation. NIV means non-invasive ventilation, and non-invasive ventilation is a method of providing ventilatory support to patients without the use of an endotracheal tube or tracheostomy. Then positive pressure is delivered through a face mask, nasal mask, or helmet interface to assist breathing. This is non-invasive ventilation. Now maintain oral hygiene and perform suctioning as needed. Then monitor and prevent mask-related pressure injuries. Encourage upright positioning to optimize ventilation. Initiate oral or NG feeding as tolerated. Minimize aspiration risk. This will minimizes the aspiration. So when a patient is in non-invasive ventilation, these things has to be done. So oral hygiene should be maintained, suction should be performed as needed. Then monitor and prevent mask-related pressure injuries. Encourage upright position, because hollow position provides more thoracic space because the diaphragm goes down, and then oral and NG tube feeding is good because there is no chance of aspiration. Then management of hypertension. Hypertensive emergency, gradual BP reduction, that is mean arterial pressure need to be decreased to 15 to 20% initially, and then it should be maintained between 160 systolic and 100 to 110 diastolic. Normal within 24 to 48 hours. IV therapy with ICU monitoring is required to reduce the hypertensive emergency. Then hypertensive urgency, gradual BP reduction over 24 to 42 hours using oral agents. Then common ICU drugs used for hypertension are beta blockers, that metoprolol, labetalol and esmolol. Vasodilators like nitroprusside, nitroglycerin, others like diltiazem, furosemide and hydralazine. These are diuretics actually. This will help to reduce BP too. Then nutrition in critically ill patients. Then generally what we do is ensure adequate nutrition based on tolerance. We cannot feed them, overfeed them, but very small frequent feeds Start early enteral nutrition within 24 to 48 hours if oral intake not feasible. Use PN parenteral nutrition only if enteral nutrition inadequate after 7 days. Then enteral nutrition for ventilated patients, orogastric or nasogastric for non-ventilated. Then post-pyloric if intolerance present. Then maintain head up position of the bed to 45 degrees. So better is the follows position. Prefer continuous feeding in acute phase. And then parenteral nutrition, when you wanted to give, use strict asepsis and infusion pump. Start gradually and then advance to target. Monitor electrolytes and metabolic responses. See, parenteral nutrition, when you give, now you have to prepare the parenteral nutrition according to the formula given, and then amount of electrolytes need to be put, the protein need to be put, and carbohydrate, all the nutritional functionaries, nutritional, all the nutrients should be inadequate in nature, and there will be formulas, and ready-made formulas are available, and also in some hospitals the nurses are taught to prepare parenteral nutrition under hygienic and aseptic conditions so that it can be given without risk. The emergency drugs and preparation and administration of these drugs in ICU. Every nurse who works in ICU must know about these drugs. The first one is adrenal norepinephrine. Dose 1 ml is equal to 1 milligram. 1:1000 is the dilution. 1:1000 IV for resuscitation. 1:10,000, that is 100 microgram per ml if BP and HR reduced, and then 1:1 lakh if BP is reduced, and infusion 0.01 to 0.3 microgram per kg per minute is the dose. Then amiodarone 1 ampule 150 milligram 3 ml. This is loading 150 milligram in 100 ml of 5% dextrose over 10 minutes, may repeat once. Maintenance is total 900 milligram per 24 hours. Then adenosine 1 ml is equal to 3 mg. Peripheral 6 mg is equal to into 20 ml of normal saline flush. Then 12 milligram. Then again after 12 milligram, then 12 to 18 milligram. If it is a central line, 3 milligram, 6 milligram and 9 milligram can be given. So adenosine, when you are giving, you must know that 1 ml contain 3 milligram. So peripheral lines, if you are using, you can give 6 milligram in 20 ml normal saline flush. That is the bolus. Then 12 milligram into again, and then 12 to 18 milligram. Then central line means first you will start with again 3 milligram, then 6 milligram and 9 milligram. Then lignocaine 2% is given, 20 milligram in 10 per ml. This bolus is 1 to 1 milligram per kg over 2 to 3 minutes. Repeat 0.5 to 0.75 milligram per kg. Fourth hourly Q. 5 or fifth hourly, like 5 to 10 minutes. Maximum 3 milligram per kg can be given this drug. Then infusion, if you are giving it as an infusion, bolus we have said, then if it is given as an infusion 1 to 4 milligram per minute, give 0.5 milligram per kg bolus if arrhythmia recurs. Then isoprenaline, mix 1 ml, that is 2 mg in 49 ml of 5% dextrose. Totally it will come to 50 ml, that is 40 microgram per ml. Then infusion 1 to 10 microgram per minute, titrate by 1 milligram per minute every 2 to 3 minutes. Do not dilute with normal saline. That must be remembered. Isoprenaline is diluted in 5% dextrose, not in normal saline like other Almost all drugs we use normal saline flesh, but isoprene, remember this is 5% dextrose. Then sodium bicarbonate 7.5%, 10 ml, that gives 10 milliequivalent, used for pH less than 7.1 or severe alkalosis with a pH 7 at or above 7.2. Then infection prevention and control in ICU. We are talking about what you may be remembering, that Huck's bid. Now we have come to infection control or prevention and control. Hand hygiene, clean hands, short nails, cover cuts. Then use appropriate PPE to prevent exposure. Maintain respiratory hygiene and cough technique, cough etiquette, not technique, sorry. This is very important, covering the mouth while we are also human beings, we also will get infections, but we have to take precautions not to give this infection to our patients. So cough etiquette is very important. Ensure environmental cleaning and adequate bed spacing. Then safe handling and transport of linen and biomedical waste. This we know the BMW protocols and the infection control practices in hospitals. So ICU we have to be a bit more careful to maintain this. Then antibiotic treatment for HAP and VAP. Approach to empirical therapy of HAP and VAP without risk factors for MDR and low mortality risk. Monotherapy covering MSSA and Pseudomonas, and then piperacillin or Lasobactam, cefepime, levofloxacin, imbibine or meropenem. These are all trade names of third generation antibiotics. This MSSA coverage should be there. Then with the risk factors for MDR or high risk mortality risk, anti-MRSA agent must be given. Then anti-pseudomonal agents of different classes. Then agent with anti-CRE activity. These are other drugs. It is mentioned in the slide. You can see agent with activity against Acinetobacter baumannii. That we may be giving ampicillin, sulbactam, like that and all. So these are the treatment given for VAP and HAP and VAP. VAP not indicated in case of VAP, that is written here. No, that star mark is like that. And these are the new protocol for treatment. ICU care bundles, that is sepsis hour 1 bundle. There are a lot of bundles available for ICU. ICU care bundles are there. So the first one is here, we are talking about safe sepsis 1 hour. Hour 1 bundle is measure serum lactate level. First thing. Second is obtain blood cultures before starting antibiotics. Then administer broad spectrum antibiotics. Then begin rapid 30 ml per kg crystalloid for hypotension or lactate less than or at 4 mmol per liter. Then apply vasopressors after fluid to maintain mean arterial pressure at 65 millimeters of mercury. Re-measure lactate if initial value is elevated more than 2 mmol per liter. This is the first ICU care bundle for sepsis. We call it as hour 1. Then ventilator associated pneumonia or VAP prevention bundle, strict hand hygiene, head of bed elevation, use of orogastric tube instead of nasogastric tube in ventilated patients, then regular oral care with chlorhexidine, then maintain optimal endotracheal tube cuff pressure, then daily sedation interruption and spontaneous breathing trial, so that there will be oxygen going by itself, and this will promote respiration and respiratory hygiene. ensure environmental cleaning and appropriate patient placement. When we say about appropriate patient placement, according to the condition of the patient, whether patient cannot tolerate cold and if patient should not be kept near to an AC. Patient should be kept away from that, so that no, they will not develop ventilator-associated pneumonia. Then central line bundle, CLABSI prevention. This is also very maybe familiar to all of you. The first and foremost for every bundle is hand hygiene. Here also strict hand hygiene with alcohol-based antiseptic. Use maximal sterile barrier precautions during insertion. Then optimal site selection and aseptic technique for cleaning. And then skin antisepsis with chlorhexidine and alcohol. Then proper catheter fixation and securement, and use sterile transparent dressing so that you can witness what is happening inside. Then complete and verify central line insertion checklist. Use multi-lumen CVCs in unstable ICU patients. So with each picture that demonstrate what is to be done for this central line bundle CLABSI prevention. How can we maintain central venous line care? We should see that we should remove unnecessary catheters promptly, maintain aseptic technique with chlorhexidine site care, change dressing if soiled and or loose, follow routine schedule, inspect site daily for infection, ensure catheter patency like blood return and flush you can do, replace infusion sets and tubing as per protocol. Each hospital will follow different protocols in this. So see what is followed in your hospital and follow it. Then urinary catheter care bundle, COTI prevention. Insert only when indicated using an antiseptic technique. You should not insert anything into any orifices unnecessarily. So even though the patient is sick, critically ill, if he can urinate by himself by providing a urinate bag or something or a vessel, that is the best way. If not, insert the catheter. But when you are inserting the catheter, maintain hand hygiene and sterile handling. Then ensure closed drainage system and the bag below the bladder, no kinks, and you should not raise the bag above the bladder. Secure catheter and perform routine perineal care. This is also very important because all portals are portal of entry for infection. So we have to be very careful, clean and provide catheter care. Review daily for early removal. Monitor urine output regularly. This is the catheter care bundle. Then delirium prevention bundle. Early identification of patients as risk. Then regular assessment of cognition and delirium. Set and maintain daily target RAS score during rounds. I'll tell you what is RAS round score. Early and adequate control of pain. Timely treatment of underlying medications. Promote early mobilization. Then implement environmental and psychological measures like noise. So because now most of the time now in an ICU there will be sensory overload and the patient may go for sensory overload syndrome. So we have to limit the noise, light and orientation issues in the ICU. So the RAS is, when we talk about RAS is a Richmond Agitation Sedation Scale. This is a standardized tool used in ICUs to assess the patient's level of sedation and agitation. It helps healthcare professionals monitor sedative therapy, evaluate neurological status, and optimize patient comfort. So the score goes like, if the score is +4, combative, violent, immediate danger to the staff, +3, very agitated, pulls tubes, catheters and aggressive. Agitated, that is 2, +2, frequent non-purposeful movements, fights with ventilator. Then +1, restless, anxious, apprehensive, but movements not aggressive. 0, alert and calm, this is a normal state. And -1 is drowsy, not fully alert, awakens to voice for less than 10 seconds. So RAS score is this, and RAS score again, Richmond agitation sedation scale. Then pressure injury prevention bundle. We know so many issues with pressure ulcers. We have a lot of tools for assessing this. First practice which we have to do is to assess the area for using a validated tool to find out whether this person is going to develop a pressure sore or not. So risk assessment using validated tool. I'll talk about the tool later. Use of pressure relieving devices like air mattress, cushions, water beds. Then reposition every 2 hours as needed. Skin assessment and care, nutrition assessment and management, moisture and incontinence management. These are the core practices. What all things we will monitor and document? Anatomical location. If there is a pressure sore or the chance of developing a pressure sore in any area of the body, that must be anatomical location. That has to be documented. Degree of injury per National Pressure Injury Advisory Panel. Peri-wound skin description must be done. Presence of odor if there is a wound. Then wound measurements if there is a wound again. Pressure injuries present on admission or developed during hospitalization. That must be mentioned. Developing a pressure sore is a bad thing, or for nurses it is a missed care or faulty nursing care. So we need to be very careful. SBIR communication framework. This is also very important. I have already told you about the communication issues and all. What is this? This framework is used why and what is it? The purpose of communication, structured tool for communication among healthcare team members must be there, and focused on patient condition and clinical concerns. So when you communicate, think about the situation, concise statement of the current problem. B, pertinent, that is the background, pertinent, brief information related to the situation. Then A stands for assessment, SBAR. So A stands for assessment, that is the clinical analysis and considerations. Again, findings and interpretation will come in assessment. Then R is for recommendation, requested or recommended action. This clarifies what is needed. Then key takeaway points. ICU provides specialized care with advanced monitoring and organ support for critically ill patients. Then continuous monitoring and systematic assessment are essential for effective ICU management. Then ICU nurses play a key role in bedside care, vigilant monitoring and early detection of patient deterioration. Then core interventions, that is fluids, oxygen, pain, nutrition, drive recovery. This will tell you how you have managed your patient. Then care bundles and structured communication tools like SBIR improve patient safety and clinical outcomes. So these are the key takeaways of ICU fundamentals. Then comprehensive management of pressure injuries. This is a very important aspect, that is why it has given such an importance in this presentation. Understanding pressure injuries. What is a pressure injury? That must be known to everybody. This is a localized skin or tissue damage from pressure or shear, typically over bony prominence or device related. Device related means I say that when you are putting an IV line, you fixate and you may, that may lead to a pressure ulcer. or you can give some chance for pressure ulcer. Then frictions, shear and pressure, these will also give for the development of pressure. Pressure ulcer or pressure injury, the updated terminologies. Decubitus ulcer, injury from prolonged pressure due to immobility. Then bed sore, tissue or skin damage from continuous pressure over bony areas. Then pressure sore, injury caused by sustained pressure or shear or friction. Ischemic ulcer, this is the pressure related injury due to reduced blood flow. Then pressure ulcer, open wound from prolonged pressure and plus or minus shear. Then pressure injury, localized skin or tissue damage, intact or open due to pressure plus or minus shear. So when we talk about these pressure ulcers, remember that if somebody is using a decubitus ulcer, this is due to prolonged pressure resulting from immobility. Then bed sore means skin or tissue damage from continuous pressure on bony prominences or bony areas. Pressure sore, injury caused by sustained pressure or shear or friction to any areas. Then ischemic ulcer, pressure injury. These are the terminologies we use commonly. Then epidemiology and burden of pressure injuries. In United States, up to 3 million adults affected annually. Global hospital prevalence of pressure ulcer or pressure injuries is 5 to 15%. ICU rates exceed more than 20%. That is about the global burden. Once you consider India burden, you will see that in hospital settings, 4 to 10% of patients get pressure injuries. ICU prevalence is 10 to 20%. That is like the global rate, depending on the risk factors and immobility. Then home care, elderly population show prevalence ranging from 15 to 32%. So the burden of epidemiology and burden of pressure injuries are not simple. It's a big amount. So a large amount of, or large section of people suffer from pressure injuries, especially elder, home care people, home-based care provided. There the rate of pressure ulcer is high. That must be remembered. Here, when we are talking about ICU, you can see that 10 to 20% of all hospital patients admitted to ICU are prone to develop pressure injury. Then pathophysiology, how pressure injuries develop. The first and foremost cause, the prolonged weight bearing and mechanical shear forces that lead to act on soft tissues overlying bony prominence. And pressure exceeds normal capillary perfusion pressure, that is about 32 millimeters of mercury. Occlusion and tearing of small blood vessels occurs that lead to reduced tissue perfusion. When there is reduced tissue perfusion, that may lead to ischemia, that is reduced ischemia and necrosis, that means ischemic necrosis. Then that lead to pressure sore formation. Key mechanical forces that develop that leads to the development of pressure injury are pressure, shear and friction. Pressure, soft tissue compressed between bone and surface, reduced perfusion and tissue damage happens, leading to pressure ulcer or pressure injury. Then friction, skin rubbing against the surface, weakening it and making it more susceptible to pressure damage. Then shear, skin and underlying tissue move to opposite direction, vessel and tissue damage. Then strain, tissue undergoes deformation in response to sustained pressure. Then immobility, that also lead to lead to pressure injuries by inability to reposition, prevents the relief of ischemic pain leading to pressure ulcers. So, how pressure ulcer develop and the mechanical forces that promotes pressure, shear and friction lead to pressure injury. Then high risk areas, common sites for bed sore. Common sites for bed sore formation include bony prominence such as hips, heels, elbows, knees and shoulder blades. So you can see this in the pictures. If patient is lying down, how it will be, and if patient is in semi-fowler's position, where all this pressure injury develops. Then risk factors, local and systemic contributors. Local risk factors are unrelieved pressure, lying in same position more than 2 hours. Capillary occlusion and disruption of lymphatic drainage, that will lead to pressure sore. Then shearing force aggravated by head and elevation to 45 degrees Celsius. Increased temperature and moisture, this also will lead to pressure sores. Then risk factors are aging, decreased mobility, fractures, paraplegia, coma, major surgery, etc. Poor nutrition, hypoproteinemia, poor oral intake, and arterial diseases and hypertension. These are the risk factors. Then early warning signs, how nurses identify early tissue damage. Why early detection matters. Regular skin monitoring helps identify pressure injuries in their earliest stages. Early recognition greatly improves prevention and treatment outcomes. So key early warning signs are persistent redness or discoloration that does not fade after repositioning, localized pain or tenderness without an obvious cause. Then skin temperature changes, warmer or cooler than surrounding areas, that leads to pressure injuries. So monitor blisters or small breaks in the skin, that also can lead to a pressure injury. So early warning signs and how nurses identify tissue damage are also very important, because a shrewd nurse will be able to detect pressure injury in the early stages itself and can prevent development of very bad bed sores. Risk assessment tools and scoring systems. See, we have a risk assessment tool called the Norton scale. This will assess the mental condition, incontinence, mobility, activity, physical condition, etc. So, risk interpretation and cutoff at or more than 12 is equal to high, 13 to 40 is moderate, 15 to 60 is low when you are using Norton scale. Norton scale will be using mental condition, incontinence, mobility, activity and physical condition. Then Braden scale. This is more, I think Braden scale is mostly used here in my place. Sensory perception, moisture, activity, mobility, nutrition, friction and shear. Here, if it is at 11, it is high. 11 to 14 it is moderate, 15 to 16 is mild, and more than 16 is equal to is use pressure relieving surface. We need to do that. Then Knoll scale, mental status, incontinence, mobility, activity, health, nutrition, fluids. It is below 10 is low. 10 to 14 at risk, 15 to 19 high, 20 very high. Then Waterloo scale, age, weight scale, incontinence, mobility, risk factors, medications, etc. This at 4 or 14 or is equal to high. Then Gosnell scale, mental status, continence, mobility, activity. The next is staging of pressure injuries, stage 1 and 2. Stage 1, the skin will be intact with a non-valanceable erythema over the bony area. may show color or temperature or texture changes. Very rarely it will happen. It shows the redness only. A stage 2, partial thickness skin loss, that is epidermis and dermis might have lost and appears as an abrasion or blister. Then advanced staging, stage 3, 4 and unstageable. Stage 3, full thickness skin loss with subcutaneous tissue damage does not extend beyond fascia. Stage 4, full thickness loss with extensive destruction involving muscle, bone or supporting structures. Then unstageable, full thickness tissue loss with obscured duct due to slough and issue. So the picture also says how it will be. Next is core strategies for pressure injury prevention. The essential preventive and supportive care measures include SS Skin is a useful acronym for essential 5 steps in general preventive and early pressure sore care. First S is standing for surface. Surfaces supporting the patient provide sufficient pressure relief. Ensure wrinkles-free bed. Special surfaces, consider using air bed or water bed. Use pillows to support the position as appropriate. So surface is covered. Then second S is for skin inspection. Early inspection enables early detection, which is when ulcers are the easiest to treat. Then clean skin, ensure regular bed bath, daily back care and prevent skin dryness with emollients. Then care for patient, keep patient moving. That we always talk about change of position. Change position every 2 hours if lying down and every 15 minutes if sitting. Then gentle exercises, range of motion exercises, active and passive exercises. Consider ambulation if not contraindicated. Then regular body movements assist blood flow and redistributes pressure. Then I4, incontinence or moisture. A clean and dry patient is likely to develop pressure ulcer, is less likely to develop pressure ulcers. Manage incontinence, regularize bowel routine, maintain perineal dryness, consider external or indwelling catheters. Nutrition and hydration, right diet and plenty of fluids and protein to help healing, keep the patient's skin healthy. Daily calorie 30 to 35 calorie per kg per day must be given to patients in ICU. Daily protein 1.25 to 1.5 kg, 1.5 gram per kg per day must be included in the diet. So in order to prevent essential preventive and supportive care must be known to everybody. Use this acronym SS Skin or you can say a skin that can be used for all these things. Then stepwise protocol for pressure injury prevention. The first one is regular repositioning, use of supportive devices, skin care and hygiene, proper nutrition and hydration, movement and exercise, chronic condition management using proper bedding and clothing. Protocol used for preventing skin. Then repositioning, we will see each one. Recommended schedule and method. Bedridden patient reposition every 2 hours to relieve pressure on body prominence. Then wheelchair users shift weight every 15 minutes, assist every hour. Then training schedule, follow repositioning plan. Example 30-degree lateral tilt, supine, otherwise side. Then use support devices like pillows, bridges, pressure reducing mattresses. Then mobilization, encourage movement sitting up, standing or assisted walking. Assistive tools, use transfer aids, mechanical lifts to prevent shear. Support surfaces, Mattresses, overlays and cushions. Why it matters? It matters because it redistribute pressure and reduce friction, shear over bony areas. Then static surfaces, no electricity. Foam, fluid, gel, air-filled mattresses, best for mild to moderate risk. So static surfaces must be given. Then dynamic surfaces require power. The other one does not need any electricity or power for working. We can buy foam mattresses, we can get a water mattresses. But dynamic surfaces require power. Alternating air pressure mattresses, air fluidized beds, ideal for high risk or bedridden patients. These dynamic surfaces are required for high risk or bedridden patients. Then skin care, moisture control, incontinence management. Why this is important? Moisture increases friction and shear and raises pressure ulcer risk. Then what we can do for this skin care? Keep the skin clean and dry to prevent maceration and breakdown. Implement incontinence skin care protocols. Use moisture barrier creams and protectants to shield skin. Perform daily skin assessment, manage wound drainage with appropriate dressings, combined with repositioning and pressure relief devices. And nutrition and hydration for prevention and healing of ulcers. Malnutrition and dehydration compromise skin integrity, impair wound healing, and increase pressure ulcer risk. So nutrition is very important. Malnutrition and dehydration compromise skin integrity, because when there is no protein, when there is no fat, when there is loss of fluid, all these make the skin more breakable. That is why we need to give adequate nutrition. So assess nutritional status in at-risk patients, then ensure adequate protein and calorie intake. Provide key nutrients like vitamin A, C, E and zinc. Maintain adequate hydration. Collaborate with the dietitians for individualized nutrition plan and diet plans. Then educating patients and families for better outcomes. When a patient is admitted to ICU, everybody is under stress. So nurses have to communicate with the patients as well as to the relatives. Once they are discharged, they need to be taken care at home. So educating patients and families for better outcome is very important. So teach simple repositioning techniques and frequency. Then encourage daily skin checks for redness, warmth or pain. Educate on keeping skin clean and dry. That means we have to control the moisture, reinforce adequate nutrition and hydration for skin healing, then explain proper use of support surfaces, mattresses and cushions, then instruct when to report early signs of skin damage, involve family caregivers in routine hygiene and monitoring. Okay, next is additional support measures to prevent pressure injuries. Movement and exercise. Encourage mobility and range of motion exercise to improve circulation. Assist regular repositioning. Use cushioned chairs to reduce pressure. Assist patient to get out of bed, chair or periodically throughout the day. Managing chronic conditions like control chronic conditions to reduce skin breakdown risk. Then regular monitoring of glucose, BP and vascular status. Review medications treatments with healthcare providers. Using proper bedding and clothing. Keep bedding smooth, clean and wrinkle free. Use pillows, foams, pads to reduce pressure on bony areas. Ensure loose, soft clothing and appropriate footwear. Overview of pressure injury management approaches. Stage-wise management protocol for pressure injuries. Stage 1, pressure relief. Relieve the pressure and reposition frequently. Maintain clean, dry, protected skin. Then stage 2, clean with normal saline. Apply appropriate dressing, avoid harsh agents. Stage 3 and 4, advanced wound care is needed. Here, debridement and advanced dressings, consider grafting, treat infection as indicated, requires medical supervision. Then next is developing a comprehensive care plan. No bed sore or bed sore should not be there. So prevention is very important. So when you wanted to make a care plan, so comprehensive care plan for preventing bed sore, please see the following items. That is the management or tools, nutrition optimization. We have said the importance of nutrition in developing pressure sore. So ensure adequate protein, calories and hydration. Then turning and repositioning every 2 hours. Customize frequency based on risk. 30-degree lateral position preferred. Keep skin clean and dry. Prevent moisture associated skin damage. Then pressure relieving devices. Application of these pressure relieving devices like foam mattresses, air filled mattress, low air, loose bed, air fluidized bed. No PRD is proven superior. Choose based on patient risk and availability. See, pressure relieving devices, no one has any superiority. So any of the pressure relieving devices available that can be used, which should be comfortable to the patient. Then manage spasticity, diazepam, acalofan and dandrolene, etc. Only if prescribed, reduces involuntary pressure on bony areas. This is a comprehensive care plan for prevention of bed sore. Then developing a comprehensive plan if bed sore is present. How can we do that? Manage tools, that is grade 1, keep clean, dry, film dressing if minimal, exudate. Grade 2, clean with normal saline, apply hydrocolloid dressing. Grade 3 and 4, saline plus dressing, and then debridement as needed. Debridement methods: wet to dry, surgical, autolytic, enzymatic, and select per protocol. Then advanced dressings: hydrogel, silver nitrate based ointments, then based on exudate and infection risk. Walk therapy for heavy exudate and more for monitor for infection. Then what are the principles of effective wound care? This can be applicable to bed sore also. Wound care is central to pressure ulcer management, with nurses leading cleansing, dressing selection, infection monitoring and debridement support. The first one is cleaning. Cleaning using saline or non-toxic cleaner, avoid harsh antiseptics. Then dressing selection, select based on a stage and exudate. Debridement, remove necrotic tissue by surgical or enzymatic or autolytic process. See, when we were students in 1980s, we used to use hydrogen peroxide as an autolytic to during this debridement stage. Then infection control, monitor signs, culture and treat as needed. Culture for organisms, blood culture, pus culture, etc. Then selecting the appropriate dressing. Dressings are selected based on ulcer stage, type, site, care setting, patient preference and cost, with the goal of maintaining a moist environment that supports faster healing. See, the different types of dressings are given here, that is hydrocolloid dressings, alginate dressings, nano silver dressings, where silver nitrate is also used, I think, creams and ointments. All these are to support healing. And then pain management and multidisciplinary collaboration. Pain management, we know that there are two areas, pharmacological and non-pharmacological. Pharmacological is analgesics, anti-inflammatory, topical medications, then non-pharmacological repositioning, relaxation, distraction. Nursing, we have to do pain assessment using visual uh, analog scale, monitor response, ensure comfort. Then multidisciplinary approach, nurses does the assessment, wound care and prevention. Physician diagnosis and medical management. Wound specialist advanced dressing and plans. Dietitian provides the nutritional support. Physiotherapist helps in mobility and pressure relief. Occupational therapist makes adaptive equipment, and psychologist coping and stress support will be done. The next, advanced therapies in pressure injury care. First thing is the growth factors and cytokinins, that is promote cell growth and wound closure in chronic ulcers. Then hyperbaric oxygen therapy increases oxygen to tissues, reduces infection, support angiogenesis and decrease inflammation. The next is skin substitutes. Bioengineered skin can be used, that is artificial dermal or epidermal layers used when natural tissue is inadequate. Next, stem cell therapy, bone marrow or adipose delivered cells to promote angiogenesis and tissue regeneration. The negative pressure wound therapy is another way. This delivers controlled negative pressure, continuous or intermittent, to promote healing of deep infected or highly exudative pressure ulcers, including those with exposed bones. This enhances granulation of tissue formation, applies uniform negative pressure to help draw wound edges together, remove interstitial fluid and decompresses tissues, removes infectious material and measures exudate output. So this is another way of treating this. You can see the picture and it is self-explanatory. Then reconstructive surgery options. Surgery is needed for non-healing grade 3 and 4 pressure ulcers that fail conservative treatment to close the wound, fill dead space and restore healthy tissue. Surgical options are split skin grafting, local flaps, regional flaps and free flaps. Key nursing responsibilities include maintain pressure offloading post-operatively, monitor for infection, flap color, temperature and drainage, assist in wound caring and dressing, support nutritional requirements for healing, ensure positioning and pressure relief devices. Then we can see clinical algorithm for pressure injury management. The first one is remove the possible and removable cause. Then improve nutrition, treat or control comorbid disease like diabetes, cardiac or renal failure or COPD. Then wound therapy. Once this is there, then you can go for slough absent, then epithelializing superficial ulcers, signs of tissue or systematic infection, slough present, discharge in ulcer or deep and dead tissue. See, slough absent, then you go for dressing, wet or moist dressing, then heals, or if it is not healed, healing continue, prevention, that is the disciplined limb care. Avoid ill-fitting footwears, prostheses, mattresses and cushions and protective devices. Control comorbid diseases. Signs of tissue or systemic infection, you have to give antibiotic. If it is heals, if it is not healing. Healing means it's okay, it heals, and if it is not healing, you may go for superficial healthy ulcer, no exposed vital tissues, skin grafting and then healing. Then heavy slough, you have to go for NPWT and sometimes effective, sometimes not effective. If not healing, again it may deep ulcer, exposed bone and muscles, then flap cover may be used. A local flap regional flap or distinct or free flaps. These are available. These are the algorithm for treating pressure ulcers. Then staff training, competency building and protocols. This curriculum development, lectures, workshops, simulation and case-based learning can be done. Then interdisciplinary approach, involve nurses, assistants, dietitians and physiotherapists. Then third, use of technology, e-learning, simulation or virtual tools. Then in the use of technology, regular updates and continuing education, stay current with the guidelines and new innovations, refresher training, etc. Then evaluation and feedback of the training through assessment of outcomes, use of feedback for improvement. Then patient and family involvement, education and involvement in prevention. Then key responsibilities in pressure injury care. The first and foremost thing is daily assessment, skin assessment, especially bronchopneumosis. Here you can use Braden scale for risk assessment. Then repositioning every 2 hours, use pillows, heel protectors, pressure relieving mattresses, etc. Third, maintain skin hygiene and moisture control, early reporting of redness, warmth or pain, managing existing sores. Managing existing sores, that means existing wound, dressings, infection prevention, nutrition support. Here for this item we may do educating parents or patients, caregivers or pressure relief measures and safe mobility. Okay, next item in this presentation is nutrition in ICU. What is malnutrition? Insufficient intake or uptake of nutrition that leads to altered body composition. That means loss of fat-free mass and body cell mass. So about 1 to 15% of ambulatory patients are malnourished. 25 to 60% of institutionalized persons or patients are malnourished. 35 to 60% of hospitalized patients are malnourished. So admission to hospital, at least 1/3 of the patients have some degree of malnutrition. 2/3 of them progress to further decline without adequate nutritional provision. This is the actual threatening epidemiology of nutrition or malnutrition. Burden of malnutrition in ICU. Globally, 1 in 3 hospitalized adults are at risk of malnutrition. Worldwide ICU prevalence is 38 to 78%. Malnutrition worsens during hospital stay, especially in elderly or critically ill patients. Then malnourished ICU patients are almost twice as likely to die than well-nourished patients. So malnutrition need to be taken care. Nutrition support is very important in hospitalized patients, especially in critical care units. So, why nutrition matters in ICU? Malnutrition causes immune dysfunction, respiratory muscle weakness, reduced ventilation, and poor GI tolerance, and increases the complication risk. The patients are on ventilatory dependence. Then gastroesophageal reflux may be there, pulmonary aspiration, infections lead to sepsis, multi-organ failure and death. And malnutrition may be present on admission or developed due to metabolic stress, associated with increased complications, longer hospital stay, higher cost and mortality. So this is why malnutrition matters in ICU. Then why ICU patients are at high risk for malnutrition? We know critically ill patients, they may have multiple organ failure, they have stress, surgery. These things increases the nutritional demand, and also catabolism and negative nitrogen balance is seen. So bed rest inactivity worsens negative nitrogen balance, and combined hypermetabolism and inactivity increases malnutrition risk. Nutritional support helps reduce catabolism, restore nitrogen balance, and prevent malnutrition. Pathophysiology of malnutrition in critically ill patients. Critical illness release inflammatory mediators leading to catabolic hormones, pro-inflammatory mediators and anti-inflammatory mediators. When catabolic hormones are there, glucagon, cortisol and catecholamines will be released. Generation of endogenous energy substrate, that is glucose, amino acids and free fatty acids. This will lead to require support to vital organ function. Then pro-inflammatory mediators are IL-1, IL-6, TNF alpha. This lead to catabolism, loss of lean body mass and then go to malnutrition. Then again anti-inflammatory mediators like TGF-B, IL-1. This lead to again maintains the homeostasis and preserve body mass. We need to provide nutritional therapy that improves nutritional status and prevent malnutrition. Muscle wasting during critical illness. Muscle mass diminishes rapidly during the early phase of critical illness. So critical illness results in reduced physical activity, increased protein breakdown, decreased protein synthesis. 2 to 5% daily muscle loss if patient does not walk. Muscle wasting, poor clinical outcomes will be the result. So clinical trajectory of critical ill patients. Malnutrition due to acute illness lead to health status before ICU stay. The factors affecting are age, chronic malnutrition and pre-existing disease. Then what we have to do is the procedures is acute phase of critical illness, approximately 1 to 7 days. Organ failure requiring life support, sedation, vasopressive drugs, agitation, unconsciousness. The procedures again will like mechanical ventilation, recovery in ICU, intolerance to enteral nutrition complications. This will lead to or affect the recovery in ICU. The progressive eating, active mobilization, weaning of mechanical ventilation. In that case, the patient may be unable to eat. High dependency, then muscle weakness, impaired cough and mobility, swallowing disorders, anorexia, high dependency, progressive walking. Then during ICU discharge also this recovery in ward, improved eating and improved walking, ICU acute weakness, fatigue, altered cognition, impaired nutritional status. This is less monitoring changes in healthcare givers. Then hospital discharge, what happens is the social constraints, healthcare giver availability. Most of the time the healthcare giver availability will be reduced, so nobody will be there to guide them or direct them about the nutrition. Sometimes even if you teach and send them, they may not take into account. Then sequelae of critical illness, persistent ICU acquired weakness, cognition dysfunction, frailty, mood disorder, impaired autonomy, decreased quality of life, altered workability, increased morbidity and mortality. All these will lead to what we call as one side we can see the catabolism with the muscle loss and the other side we can see anabolism. Malnutrition, enteral nutrition or parenteral nutrition with low calorie and the protein intake, early mobilization lead to standard nutrition status or standard calorie and protein index, increased mobilization. Follow up by nutritionist, physiotherapy and adapted physical activity and occupational therapy. This will help in removing malnutrition from patients. Then rationale for use of balanced nutrition in critical care. Adequate nutrition is essential to prevent and treat hospital malnutrition. Higher protein intake stimulates muscle protein synthesis, prevents loss of muscle mass, enhances recovery. So protein must be taken in a large amount, like consumption of 60% of protein shorten the length of stay in the hospital. So this is a research found, and so nurses must be vigilant to provide a balanced nutrition to the patient with a higher protein intake. The nutrition assessment and initiation in critically ill patient. So assess nutrition in all ICU patients on admission. Identify malnutrition signs, cachexia, edema. Start early enteral nutrition within 24 to 48 hours if possible or feasible. Then consider parenteral nutrition if enteral nutrition is not possible. Treat nutrition as therapeutic, not merely supportive. Monitor electrolyte closely. Assess drug nutrition in nutrient interactions. Initiate tube feeding if 50 to 60% targets met within 72 hours. Then feeding practices in hemodynamically unstable patients. Start enteral nutrition at low rates after stabilization on or at vasopressors. Then initiate use enteral nutrition with 24 to 48 hours once stable. Avoid early enteral nutrition in persistent shock. Monitor gut function and when hemodynamically stable. See, this picture shows hemodynamic instability called as anemia. See that the oxygen need to be measured, IV fluid need to be resuscitated, then urinary catheter will be there, surgery or critical care, whatever it is. When all these things are there, these areas must be taken care. Nutrition screening and assessment. Assess using subjective global assessment scales. Monitor daily and adjust nutritional plans. Conduct assessment by trained ICU nutritionists. Maintain nutritionist patient ratio of 1:25 in hospitals, so that now all ICU patients will get a nutritional assessment and nutritional support therapy. Use CT or ultrasound to assess lean muscle mass wherever possible. Nutric scoring system. If interleukin 6 available, sum of points for category and explanation. Then 6 to 10 high score associated with worst clinical outcomes, that is mortality and ventilation. These patients are the most likely to benefit from aggressive nutrition therapy. Then 0 to 5 low score, these patients have a low malnutrition risk. Then if IL 6 available, 5 to 9 high score associated with worst clinical outcomes, mortality and ventilation. Then those patients are most likely to benefit from aggressive nutrition therapy. Low score, these patients have low malnutrition risk. So not very estimating energy and protein requirement. Say protein requirement 1.2 to 2 gram per kg body weight per day. Then hypercatabolic states, the kilocalorie nitrogen should be 120:1 or even 100:1 has been accepted. Nurses document daily calorie intake and report deficits. The calories must be 25 to 30 kilocalorie per kg body weight per day. Use the Rondo formula for burn energy needs, adjust per monitoring. This is how we can identify the protein requirement. Then recommended energy protein requirements to use in ICU. Energy individuals validated equation in the absence of indirect calorimetry. Use 25 to 30 kilocalorie per kg or predictive equations or indirect calorimetry. Then 20 to 25 kilocalorie in acute phase of critical illness. Then 25 to 30 kilocalorie per kg in recovery phase. Then 25 kilocalorie per kg, consider hypercaloric feeding in critically ill obese patients. Then protein 1.3 to 1.5 gram per kg. Then for normal people 1.2 to 2 gram per kg if BMI is more than 30 kg per meter square. 2 gram per kg ideal weight if BMI is 30 to 40 kg per meter square. Then 2.5 kg ideal weight if a BMI is more than 30 kilogram per meter square. Caution with excess of nitrogen in severely ill patients. Then practical approach to provide proteins and calories during the phase of critical illness. Say day 1 25% acute phase, then day 2 50%, day 3 75%. Then post acute case, the day 4 target 1 you can give 100% proteins. Minimum protein intake is 1.3 gram per kg per day. Then target 2 post ICU target, you can see increase the protein up to 1.5 to 2 grams of protein per kg per day. Then target 3, that is the convalescent period, you can use 2.0 to 2.5 grams of protein per kg per day. This will increase, you can have early mobilization, exercise and rehabilitation. These stages are considered like that. Then recommendations, you can see acute phase 1 to 4 days, monitoring phase, monitor phosphate, stay at 25% of calorie target for 48 hours, prevent very early protein intake. Then post-acute ICU phase, day 5, adjust calorie intake, non-nutritional calories from glucose, propranolol and citrate. When feeding is reduced to prevent overfeeding due to non-nutritional calories, use very high protein feeds or protein supplements. Indirect calorimetry and adjust target accordingly. Consider to monitor nitrogen balance. Then post ICU phase, patients are at risk for reductions in calorie intake after cessation of enteral nutrition. Patients are at risk for reductions in protein intake after cessation of enteral nutrition and feeding tube removal. Monitor oral intake. Do not remove feeding tube early. Consider use of muscle ultrasound, BIA, DXA or CT body composition. Then post-hospital discharge. Patients are at risk for prolonged reduced caloric intake. Consider use of oral nutrition supplements. Patients are at risk for prolonged reduced protein intake. Consider use of oral nutrition supplements. Then monitor oral intake and oral nutrition supplement intake. Then consider functional muscle test and follow up of body composition. When and how do you decide feed time? Recommendations for nutritional management based on nutritional status. ICU admission, screen nutrition risk within 24 hours, assess severity, ICU stay 48 hours is at risk. Risk scoring, low risk for malnutrition, can the patient take orally? Yes, they can go for oral route or consider EN. Feeding mode can be like that. Then high risk, start early nutrition. Enteral nutrition is preferred over parenteral nutrition if oral not feasible. Determine energy needs via IC, VCO2 and weight based and predictive equations. Aid to decision making for nutritional support in ICU. Should the patient be fed via stomach? No or yes. No means low nutrition risk, CVS unstable. The yes means high nutrition risk, CVS stable. Then if this is not possible, absolute contraindication, we will go for parenteral nutrition. Then if there is no other things, they can be fed by themselves. Yes, if they are voluntarily taking food, then it is yes. Otherwise, enteral nutrition can be given. And a relative contraindication, will the risk subside in 48 hours? We will not be able to say no. Then tropic enteral nutrition, and if it is tolerated, full enteral. well tolerated, again full enteral. Like. Then tube feeding and risk of nosocomial infections. Prefer NG to use jejunal if indicated. Continuous feeding via pump or gravity with the 8 to 12 French tubes. Then check tube position and patency before feeds. Maintain strict hygiene to prevent contamination. Prefer standard formula or closed ready to hang systems. Avoid blenderized feeds due to high risk of bacterial contamination. Elemental diets, long-term use may increase Clostridium difficile risk. Then monitor contamination sources and ensure safe handling. Enteral nutrition, when to start and when to avoid. When to start with 24 to 48 hours once hemodynamically stable. Then trophic or full feeds as per status, 10 to 20 ml per hour can be given. The nasogastric tube first line, post pyloric if aspiration risk or intolerance. Then monitoring during initiation use, prokinetics for intolerance, do not stop for diarrhea unless other cause, GRV above 500 ml, then acceptable without intolerance. When to avoid or delay in enteral nutrition, hemodynamic instability or uncontrolled shock, then increasing vasopressors, suspected bowel ischemia, high output fistula, severe vomiting or obstruction. Special considerations, not cautiously on prolonged vasopressors, minimize feed interruption during procedures. Then enteral nutrition, formula selection, monitoring and key issues. Formula selection, standard polymeric formula first line, fiber formulas for diarrhea, semi-elemental only for intolerance and metabolism. Monitoring and tolerance and adequacy. Confirm tube position. Prefer continuous feeding, intermittent if suitable. GRV that 300 to 500 ml acceptable, no hold more than 500 ml without symptoms. Monitor distension, vomiting, stool and intake adequacy. Then managing enteral related issues, usually diarrhea, continue enteral nutrition, review meds, consider fiber or semi-elemental nutrients. Then vomiting and aspiration, elevate HOB, that is head of bed, 30 to 45%, prokinetics, post pyloric if needed. Avoid unnecessary feed interruptions. Monitor NG tube complications, sinusitis, ulceration and pneumonia. Then parenteral nutrition in ICU. If delivery of nutrients, that is carbohydrate, protein, fats, electrolytes, vitamins and trace elements when enteral nutrition is inadequate. So what will you? ESPEN recommends starting PN, that is parenteral nutrition, after 3 to 7 days if enteral nutrition is insufficient. Early parenteral nutrition does not improve mortality or ICU outcomes. Late PN improves survival, reduces ventilation and infections. Then prefer ready to use ternary mixtures. Vitamins and trace elements must be supplied separately. High calorie protein parenteral nutrition requires central line. Usual complications are infections, hyperglycemia and liver dysfunction. Route of nutrition, enteral to feeding versus parenteral. Prefer enteral over parenteral nutrition. This is because enteral nutrition is a gravity feed. Parenteral nutrition is you have to use peripheral lines or central lines, usually central lines. Then avoid routine enteral nutrition and parenteral nutrition combination, use only if indicated. Either one, either enteral or parenteral. Combining both are not advisable. Then avoid early enteral nutrition in hemodynamic instability. No mortality benefit is there. So feeding mode, assisted enteral indications, functional gastrointestinal tract, enteral access can be safely placed and maintained, hemodynamically stable, improving from shock. Then need for long-term nutritional support, we go for enteral nutrition in these conditions. Then we may go for parenteral nutrition when non-functional gut, unable to tolerate EN due to severe GI issues, severe hemodynamic instability, when malabsorption, short bowel syndrome, high risk of aspiration or EN related complications. Then standard nutrition in hepatic failure, prefer central nutrition in liver diseases, restrict sodium only if indicated, no added benefit of BCAA formulas in encephalopathy on antibiotics. Use whole protein formula 35 to 40 kilocalories per kg per day, 1.2 to 1.5 gram kg per day protein. Avoid protein restriction in refractory encephalopathy. Provide protein supplementation. Calculate needs using dry or usual weight. Then standard nutrition in traumatic brain injury. That early enteral feeding with adequate protein to counter hypermetabolism, prevent muscle loss and support recovery. Early enteral nutrition within 24 to 48 hours post-injury once hemodynamically stable. And then consider arginine-based EPA or DHA supplemented formulas. Protein recommendations should be in the range of 1.5 to 2.5 gram per kg per day. Then standard nutrition in respiratory compromised patients. Use calorie-dense enteral nutrition in ARF, especially with fluid overload. Then small frequent feeds should be preferred to improve nutritional compliance. Monitor and replace serum phosphate as needed. Avoid high fat, low carbohydrate formulas in ICU, ARF. Then no added benefit of disease specific low carb, high fat supplements in stable COPD. Then standard nutrition in acute kidney injury. Use standard enteral formula in AKI. Do not restrict protein in renal insufficiency. Protein requirement is 1.2 to 1.7 gram per kg per day. Ensure adequate non-protein calories. Use renal specific formula if significant electrolyte imbalance is there. Then documentation of nutrition practices. Document nutrition care from diagnosis through monitoring. Maintain collaborative documentation by all team members. Inadequate documentation practices hinder quality. Illegible record impair documentation. Poor recording of calorie or poor protein intake limits quality. So documentation of the below mentioned is recommended. Screening and assessment tools used along with their scores and weekly reviews scores. Nutritional diagnosis, nutritional care plan on daily basis, infectious complications and stool frequency on daily basis. Then ICU nutrition protocol is given here. You can read it on your slides. And takeaway messages: start nutrition within 48 hours once hemodynamically stable. Prefer enteral feeding, encourage oral first. Use standard formulas over blenderized feeds. Use parenteral nutrition only if enteral nutrition not feasible or tolerated. Initiate low dose, reach targets in 3 to 7 days. Do not stop feeds for GRV of 500 ml alone. Screen all patients for malnutrition. Follow unit nutrition protocols. Thank you for patient listening. Thank you very much. Hope you understood something about ICU care, and it's a very vast topic. Within a short period of time I could I have to complete it. Require more explanation, if so, you can contact me or contact the people who are giving you this lecture. Thank you.